Hi, everyone. Doc T here with another episode of the Horses Advocate podcast. Thanks for mucking through the Florida Equine Veterinary Association's meeting with me. I'm trying to bring to you the highlights of every meeting that was presented that I attended and bring to you the information that would make sense to all of us. And sometimes I get more confused than not, but when it comes to upper respiratory diseases, this next section is all about that. Dr. Nicola Pusterla, Pusterla, with a very thick accent, presented everything we needed to know about upper airway disease, specifically the viruses and bacterial. And if you want to really break it down into that, you can just say Strep equi, which is the cause of strangles, and then all the viruses such as influenza, herpes virus, and those are the big ones. So the gist of this is it is a diagnostic nightmare for veterinarians to try and figure it out. So we have to do a little bit of separating and what they call triage in a way. You have to look at the age of the horse, whether the horse has been on the farm or has gotten off the farm, where the source of the infection came from. And the first thing he suggests is that we separate between Strep equi, bacterial infection, and the viruses. And in a nutshell, if the horse is older than 5 years old, or five or older, and it's a quarter horse or it's a pleasure horse, and it's a spring and summer, it's probably Strep equi. And then he said if it's in the fall and the horse is less than 5 years old and it's a thoroughbred or a competitive horse in competition, it's probably a virus. So that's great. I mean, super. But 34% of them were just common pathogens, but 66% were unknown comorbidities that made these things worse. So it's just a difficult situation for your veterinarian to be in if he or she is called out to look at a horse with an upper respiratory disease, which is basically a fever, nasal discharge, and coughing. Fever being over 101.5 degrees Fahrenheit. You guys can convert that in Celsius if you want. He did say that 50% of all diseases of upper airway are in less than or equal to 5-year-olds. So, but more in performance than in isolated horses. That makes sense. In other words, if you're going out of the barn, going seeing other horses, you have increased chance of getting it. And 34% are positive for at least one pathogen on the PCR. PCR is polymerase chain reaction. You might have heard about this during coronavirus, how they were testing blood and they were isolating what exactly was causing the disease. So, interestingly, in the equine herpes virus, number 4, it was 9.9%. Equine influenza was 9.5%. Strep equi was 8.6%. Equine rhinovirus is 4.9%. And equine herpes virus number 1 was only 2.3% of all illnesses tested in his lab. So it's, to me, it could be any of those. So he started to delve into each one. The first one was equine influenza virus, sublineage Florida, or what he says, Florida sublineage. And it turns out that the Florida sublineage of the equine influenza virus is a leading respiratory pathogen in the United States. Now, they have something called clade, C-L-A-D-E. I'm not too sure what it means, but they have clade 1 and clade 2. And what they found was clade 2 is the highest in Europe, and they're starting to see it in the United States. But in the United States, it's clade 1, and the vaccinations in the USA are for clade 1, but they're starting to see an antigenic drift, making the vaccine not as effective. They said that it's usually a disease of youngsters, 5 and less years, and it peaks in March. And the question is, do you give the modified live virus or do you get killed to get better coverage? And there's still a question. We don't know which one works better. The next upper respiratory viruses called Equine Herpes Virus number 2 and 5. It's widespread, lives well without disease. The odds ratio is low. Forget me talking about odds ratio. He threw that in there. Odds ratio is outcome to risk, and basically EHV5 is more common than EHV2, but possibly a higher probability of disease when EHV2 and 5 are together. But basically, nobody really worries about equine herpes virus number 2 or 5. He did want to go over equine rhinitis virus, which the median age is 3 years old and is linked to mild asthma. And he concluded, and I know it sounds like I'm skipping over a lot, but this is just what he went over. Basically, equine herpes virus 1 is the one to worry about. And let's see, he said it's frequently in the young performance horses, greater risk. And there's an increasing frequency of equine influenza in vaccinated horses. So his best advice is to minimize exposure and vaccinate only on exposure risk. This is what I've been saying since 2007. Don't vaccinate for diseases your horse is never going to be exposed to. If it's a pasture ornament in the middle of nowhere and never leaves the farm and no other horse comes to it, don't worry about it. But if your horse is in competition, leaving the farm all the time, they're going to be at a higher exposure rate risk for equine infectious or equine influenza. He did really stress to avoid multivalent vaccines. What that means is if you're getting a vaccine for your horse that has 5, 6, 7 different diseases all in one syringe, you should avoid that. That brought joy to my heart because I've been saying that for a long time. He said what I said: vaccinate for the diseases that will kill your horse, like rabies and tetanus, and encephalitis, keep them separate. And if you have to vaccinate for these viral diseases like herpes virus or influenza, you should do that at a later time, at a separate injection. And I could not agree any more than that, which is sometimes rare that I do that at these meetings. Okay, so then his next talk was about coronavirus in horses. Any reason to panic? And I thought that was interesting. And the reason why there could be panic is he said that the minks in Europe got SARS-CoV-2 from humans, and then it mutated and came back into the human population. And that forced all the minks in Europe to be euthanized, which if it hopped into horses and then hopped back into humans, that would be very, very devastating. So he just want to remind us that that's a possibility. But can horses get or give SARS-CoV-2? Remember, SARS-CoV-2 is the virus, the name of the virus that caused COVID-19. There's also MERS-CoV, which was Middle East respiratory virus. And that was a coronavirus. And it was only in the Middle East, and the intermediate was the camel. So it never even got to America. They also had a SARS-CoV-1 before that. And we've talked about this before in past podcasts, I believe. But we're just talking about SARS-CoV-2. And can you get the equine coronavirus? And yes, there is an equine coronavirus. It's similar to the bovine coronavirus, which is really interesting. In fact, in determining which one is which, it's very difficult. They're so close. The good old cattle out there have something similar. But it can cause dysentery, which is upset of the GI tract with diarrhea, or it can cause respiratory. So the bottom line is, yes, they are susceptible to SARS-CoV-2, horses are, but they don't shed and there's no seroconversion. So that's really good, which means if a horse gets SARS-CoV-2, they don't convert over and show an energetic response. It's basically, from what I believe, a dead-end host. So the virus just fails to live inside a horse. I think that's what he said, because he went on to say out of 587 thoroughbreds that were between 2 and 7 years old, 36 of them were seropositive horses for the human SARS-CoV-2. So they didn't show any infection. There was no disease. So these are people who went out and actually just randomly sampled some horses, and they said, okay, 6% of these horses that we tested actually showed that they had antibodies to the SARS-CoV-2 virus. So it was a poor study, according to the presenter, meaning that the statistics weren't really good and it didn't show anything but correlation. In other words, not causation. So then there's another study of 1,186 horses, and they were between 1 day old and 43 years old. And these are hospitalized horses. So they're in a hospital, they drew the blood, and they said, okay, how many have SARS-CoV-2? And of the 1,186, only 42 had them, and that's 3.5%. And again, they did not have any sign of coronavirus disease from humans. So they're not really worried about it. They thought it was more common in the spring. But the bottom line, avoid people, dogs, cats, and maybe horses if you are positive for SARS-CoV-2. So if you're tested and you have to tell people that you've got COVID, just stay away from your dogs and cats because they've been known to get the disease from humans. Avoid people if you're shedding, and you're still going to have to go out and muck your stalls, but just for about 2 or 3 days, he said, try and avoid getting around your horses. Have somebody else do it. I thought that was interesting because SARS-CoV-2 isn't causing a disease in horses, but it is showing some seroconversion, which is confusing because they said horses don't seroconvert, but that's typical of these talks. I get sometimes confused, and that could be that they were confused. They said the wrong word. Anyway, so what is equine coronavirus? That is not SARS-CoV-2, the one that causes COVID-19. Coronaviruses have been around for a long time. And in the equine variety, it causes lethargy, anorexia, and fever. It can cause diarrhea in some horses and colic, but in one horse head pressing. But here's the number one thing you have to remember. It's self-limiting. So if your horse gets equine coronavirus, it's going to be nursing care, and in 2 weeks, it's over. In fact, he said at the end of it, he said, if you're ever going to have a disease outbreak on your farm, hope that it's equine coronavirus, because you just don't worry about it. The horses hardly show any major signs. They don't die from it. They get some diarrhea, a little bit of colic. They're kind of low-key with a fever, but they get over it and everything's fine. 91% of them will be off their feed. 81% will just be like under the weather, lethargy. 74% will have fever. 21% diarrhea or soft stool. 12% will have colic. There can be anywhere from 20 to 80% morbidity, but it lasts about 2 to 3 weeks. Clinical signs are gone in 3 to 4 days. And that's the most important thing. So if your horse is sick, just give them good nursing care. In 3 to 4 days, they are going to be okay. The biggest thing is PCR is going to be positive for these horses. So you run a blood test and your vet's going to come back and say, yes, it's that. But you can also see the blood work. It's also going to show a viral infection as the white blood cells get lower in the blood. So let's see what else. Okay, you can detect with PCR, polymerase chain reaction, in 3 to 9 days, and they'll shed the virus for 6 days, peaking at 2 days. So again, keep everybody on the farm, kind of isolate it, don't spread around your farm, do a little bit of biocontainment. Don't be walking between barns or turning horses out together because it'll go through it. But if it does go through your barn, it's going to be self-limiting, and that's the takeaway message. Let's see. Oh, he did say they can be painful. So it comes on really quick. It can be a little painful. A little Banamine, keep the fever down, make them feel good, but it's over in 2 weeks. Okay, so it's non-specific signs, plus or minus GI signs. and lymphopenia, which is low white blood cells, you think equine coronavirus. You can confirm that with a PCR test, and it's self-limiting and supportive care. That's the bottom line. So how am I doing? You guys still awake? Let's go on to the next presentation by Dr. Pusterla, and it's called protozoal myelo what? Updates you must know, especially if you don't know how to spell it. Yeah, it was kind of funny because some of us veterinarians are very good at spelling, and then, then there's me who can't spell worth beans. So he basically said you have to look at a couple of things. Look at the clinical picture. So we're talking about protozoal myelitis, or EPM, and that's caused by a specific organism, S. neurona, and it can affect any region within the central nervous system. So the signs are dependent on the affected regions. But if it's in the spinal cord, you're going to get weakness, ataxia, and muscle atrophy. But the hallmark of this disease is that it's multifocal. In other words, it's not just in one spot, but it affects several spots, and it's progressive, and it's asymmetric. So it could be the left hind rump, it could be the right shoulder, it could be the left head, it could be anything. So if you have a multifocal, progressive, asymmetric disease of weakness, ataxia, muscle atrophy, then you have to do immunodiagnostics. If your horse just has poor performance, it is not a sign of EPM. You just want to make sure that we all knew that. And I know a lot of people say, well, it's either Lyme or EPM. And he says, no, you have to have some of these signs. Unfortunately, those muscle atrophy doesn't occur right away. Here's another interesting fact. 68 to 84% of healthy horses will test positive for S. neurona. And again, that's the cause of Sarcocystis neurona, is the causative agent of EPM. And if like 3 out of 4 horses are going to test positive, how good is that diagnosis? Because they're not showing signs or may have come and gone. It said 26 to 41% of healthy horses will test positive for another one called N. hugesi, Hughesi, Hugesi. And that's another protozoal disease. So therefore, titer for EPM does not equal the disease. Let me put this in different terms. He's basically saying if you've got a horse that isn't showing signs and you start doing blood work, testing for Sarcocystis neurona, which is the causative agent of EPM, well, most of them are going to be positive, but you're missing the other one. So you have to test for 2 of these. And it's going to get to a third disease, which you may never have heard of. The only thing you can get is a cerebral spinal fluid tap. So once you do a spinal tap, if it's negative, then there is no disease. And if it's positive, then it's either you've got the disease or you contaminated it or there's diffusion someplace. And so what they do look for is an antibody ratio of serum to CSF, and that really helps diagnose it. So number 1, do a case definition, do a good workup, and maybe think that it's EPM. Number 2, do serum titer, do CSF tap, and look for the serum CSF ratio, and that's going to support your diagnostics. However, if you can't do the immunodiagnostics, mainly because people don't want to follow up, they don't want to spend the money, they don't think the horse is worth it, you need to treat for a minimum of 2 weeks. If there's no improvement in 2 weeks, then look for another cause. If the horse does improve, then keep treating. And we really don't know how long to treat, but as long as the horse is improving, keep treating. So that, I won't say is the poor man's way, because treatment is expensive too. But if you don't have the ability to do the diagnostics and you just want to start treating, go ahead and treat. And if you have improvement in 2 weeks, great. If you have no improvement, you're treating the wrong disease. And I thought that was pretty good, because a lot of people just like to put the horse on marquee or something, some sort of drugs, and they think they're covering it. Anyway, the third one we want to talk about was Toxoplasma gondii. Gondii, which is always been for me in cats. You know, this is why I don't handle feces of cats, because you can get it too. It's a public health hazard. It's rare. It can cause abortion or ocular diseases. And if the horse has a high titer, you can have signs that are similar to EPM. And warm bloods are more susceptible to EPM. So if the horse is negative for Sarcoidosis neuroni, you must test for Sarcoidosis hugesi and Toxoplasma gondii. Does that make sense? So if your horse is showing signs of EPM, but the blood test, the PCR comes back negative for Sarcoidosis neuroni, you have to test for these other two diseases. And let's see, what else? Prevention. Well, you have to look at risk factors: age, the season, prior EPM disease, and how much wildlife contact, because you have to have the opossum and contact of the opossum poop to get EPM. It's necessary. It doesn't jump from the opossum to the horse. It's got to go through their poop, and that poop has to be in the food, and the horse has to be ingesting it. So good cleanliness, sanitation around the farm is really important. Feed off the ground. Make sure you have fresh water. Don't get water that's can be contaminated. Prevent contact with wildlife. There is no vaccine. You can do diclazeril, and he gave some doses, and that's between you and your veterinarian if what you want to do. But he says basically there is no shortcut in diagnosing EPM. You can avoid immunodiagnostics if there are no clinical signs. It makes no sense. There's no clinical signs. And avoid treating and seeing. In other words, avoid just treating and see what happens. But if you're forced in a corner and there are clinical signs, go ahead and treat. But there is no prevention for it. So that pretty much sums up his viral episodes, presentations. I don't think there's another one. I'm looking right now. That's number 8. My notes are scattered about. Yeah, oh, that's it. That's right. He only had 3 presentations that day. I got it. Okay. All right, everyone, take a breather, stand up and stretch. If you're driving, too bad. Let's move on to the next group. Good grief. Oh, okay. Yeah, I know. I've got scattered notes. Please forgive me. Okay, so we're looking at, yeah. This is Dr. Jean-Marie Denois, who is very French, very thick French accent, probably the world's most authority on lameness caused from the spinal cord. And he just basically breaks the horse into 3 parts. The first part is the head down to the front legs. The second part is between the front legs and the hind legs. And the third part is the hind legs back. And a lot of people looked at the spinal cord or the spine of the horse as being a suspension bridge, where the 2 foundations of the bridge are the legs, the front legs, the hind legs, and the vertebrae kind of in between there. But we also know the vertebrae go beyond the front legs up toward the head, and of course beyond the hind legs back through vertebrae into the rump. And so this first talk was about the cervico-thoraco-brachial syndrome. And it was fascinating because I got to see so many videos, and I've actually seen his presentation before at the AAP. He goes so fast, but he really urges us to look and see what we've got. And all I can tell you, there's so much to tell you, but all I can tell you about injuries to the spinal cord in the cervical or neck regions was almost all of it was from trauma. And there are fractures of the articular processes, also misalignment of the spinal canal. So there is not a normal intervertebral disc. That's the disc that sits in between the 2 vertebrae, kind of like if you knew railroad cars and you want to walk from one car to the next, there's that little bellows in between there so you don't get exposed to the wind and stuff going by. That's the intervertebral disc, and the disc are the railroad cars, and you can walk from one car to the next. That's what your spinal cord does. It goes through the protective structures of the vertebrae in a hole, and they have to line up pretty well. If they don't line up, they start to pinch the nerve. And when you pinch the nerve, you're going to have a neurological deficit. In addition, if you go back to that railroad analogy, there are also two other articular processes. I think a better way is if you can just imagine you have one of those round exercise balls and you place it on your belly and walk up to another person and they press on the other side. So between you two, there is an exercise ball that you kind of squish. And then you reach both hands up and you grab the two hands of the other person and you stabilize yourself by locking hands. Those two hands are the articular processes. This one's on each side of the vertebrae, and the ball that's between you is the intervertebral disc. And then above that, going through your chest, imagine there's a hole, and that's where the spinal cord goes through. So, and then there's a ton of them. There's like 7 in the neck, and there's 18 in the thoracic vertebrae, which is between the front legs and the hind legs. And then you go into the sacrum and the lumbar, and then the sacrum. And that's the morphology of it. So in this presentation, they looked at the C8T1 and the first rib. And this is what I found fascinating, because when you had instability, again, think of yourself holding that ball between your friend and holding each other's hand. If one hand kind of collapses, you're not going to be standing perfectly aligned. You're going to kind of tilt to one side because something's wrong with your hand connection with the other person. And there's nerve roots coming out, and they start to get pinched. When that happens, you get decreased nerve transmission, and therefore the leg doesn't work properly. It starts to lag. It doesn't extend all the way, or it doesn't have enough pulling power, propulsion, or it just is numb. It just has a tingling sensation. This is all because the vertebral segments aren't aligned properly. And unfortunately, a chiropractic adjustment isn't going to help this because there's a defect in the bones. So these young horses were having a defect in extending their front legs all the way out. They just wouldn't go out. There was asymmetrical, and increased workload made it worse. And through some radiographs, x-rays, that use a lot of juice. And as my friend at the conference said to me, he's got more juice in his machine than I've got out in the field. And it's true, because when you take an x-ray, you have to go burn through the shoulder blade to get the vertebrae that you're looking at, and then burn out the other shoulder blade. It's quite, you can't do this just willy-nilly. It's going to take some really good techniques to find these. But this is what he's done. And he found that these articular processes were not working, or the ball between you two, the intervertebral disc, wasn't properly aligning. But then he also saw something called agenesis or hypogenesis of the first rib. And that was absolutely fascinating. The first rib in the x-rays was either short or was completely missing. And this is just a birth defect. And nobody knows why this happens. But when that happens, that rib is articulating with the vertebrae up in the neck and the first thoracic vertebrae. And when that's missing, you're going to get pinching of the nerve that's going to affect the leg a little bit further down the line, and it's going to present differently. So we all got the opportunity to look at, 6, 8, 10 cases, each one with a little bit different pathology, all in the last 6, 7, 8 vertebrae of the neck and the first vertebrae of the the thoracic vertebrae and the first rib associated with all that. And it's mind-blowing. It's absolutely mind-blowing when you start to look at these horses, because they're not lame from pain, like a sole abscess, like, your horse steps on a nail and it hurts, or a bowed tendon or suspensory ligament. That's pain. That's lameness from pain. This is lameness from a neurological deficit, which shows up completely differently. You can nerve block the leg from the bottom all the way to the top, and it's not going to make any difference in these horses. They are still asymmetrical. So remember, an asymmetrical horse doesn't mean a lame horse. It just means that it's not symmetrical. And a lot of horses go just fine with asymmetry. So do you and I. We do our life just fine. We may not be able to compete at the highest levels, but some of these horses are trying to compete at the highest levels. And because of these nerve deficits, they're being brought in for evaluation. And most of them are just retired or, frankly, euthanized, because they're never going to get any better. These injuries that have occurred to the neck are probably from the horse falling down years prior. And over time, they're getting these arthritic changes. And you just can't go in and inject or do surgery on these things. It's just not possible. So I thought that was fascinating. And in the next lecture, he moved on to the thoracolumbar, which is basically in between the two limbs. And what I found fascinating is when a normal horse walks, every time he walks, the vertebrae are going to hunch up and then swing down. So they're going to create a small mound in the back and then a small valley, small mound and small valley, back and forth. They're just going to rock up and down. That's normal. It's supposed to be flexible. And if there's pain in that, the horse is going to stiffen. So every time the horse walks, the whole back is going to remain as one vertical or horizontal unit bouncing up and down. And it was quite obvious when you looked at these videos, the difference between a normal horse and a horse that is bracing and guarding himself due to multiple reasons. They're able to take normal horses and do some computer imaging, which I thought was amazing. And they showed that the axial muscles stabilize the flexion and the abdominal muscles stabilize the flexion. So if they didn't have good top line, good abdominal muscles, the flexing would be even more exaggerated. So the horse braces to a degree, but when there's pain, they can absolutely stop moving the flexion of the vertebrae. So one of the things was calcification of the interspinous ligaments. And that means every vertebrae has these spines that stick up. That's what makes the withers. And he found that there was some calcification in between them. This is not kissing spine, but it could be the beginning kissing spine. But he found that that could be the beginning of some of the pain in some of these horses. Spondylosis, which is on the bottom side of the vertebrae, which is, I mean, you have to have a really good x-ray machine to see the bottom side because you're going through so much mass of the horse. And he cautioned in 2 lectures, he says, be careful of the radiation because you can expose yourself to too much radiation doing these things. So you really have to know what you're doing. But they can see some bony proliferation between the vertebrae on the bottom side of the vertebra. So again, going back to the analogy where you have that ball between you, this is growth that is below that intervertebral disc that's not allowing the vertebrae to move up and down properly. And in fact, it creates a lot of pain. He went on, he said, you should trot these guys in a circle on a hard surface, and you're going to see stiffness and decreased flexibility. And he's going to keep his weight on the ground by making the trot a 4-beat. And it's awesome to see, awesome to vet, but not to the horse, because the horse just wants support all the time. It doesn't want to be lifted off the ground like in a trot where they're going back and forth in a 2-beat. They go into this 4-beat walk, which is kind of interesting. He also said if you put this horse on soft surface where they're a little bit they can't brace against it. Be careful, because the horse can really buck during the exam, and he showed a horse kicking out. So, and then he says at the canter, again, no flexion in the back, almost like a rocking horse, and you may not want to, and they may not even want to canter. They also said that some of these horses have stiff necks, so they can have normal cervical vertebrae, but the thoracic injury is very severe. And so they just become unable to bend laterally. So when you put them in a lunge to one side, it just looks like a plank going around. Nothing's bending. And then if you go the other direction, you might see some lateral bending where the horse bends his neck and leans into that turn. So it was just fascinating. These horses buck, they won't extend. They have poor, sharp turns, which is really important for a horse that's, on the jump course and they have to make a sharp turn. They can't do it, and they try to approach the next fence, and they usually fail because they can't turn laterally. So you have to look for asymmetry in the lateral flexion, as well as the up and down motion. And then he used a term called myopenia, which is lost muscle or muscle atrophy. There's just a word that's different. Sarcopenia is lost muscle. So it's just the same word. They start to have disuse atrophy, which you can see, which of course you're going to say maybe he has EPM, but in this case, he's just not using it. Fascinating to watch all these horses and how severe they can get. And it's quite sad, actually, to see all these horses and the lamenesses that they could have. Then he ended up with the sarcoiliac injuries. This is the hip where it connects to the vertebrae and behind. And they're usually traumatic fractures. And he actually showed a bunch of racehorses that were just flipped over and landing on their rump, on their back, before the rest of the body hits the ground. And these guys just are fracturing their hips. And what's interesting is you might not be able to see the fracture at first, and the horse is still doing most of what you're asking. But when you ask him to do a little bit more, they just say no. It's just not going to happen. So it's common in race horses and sport horses. And one of the most interesting features is when you canter the horse in a circle, both hind limbs move almost together. Instead of bringing one hind leg up and it lands on one hind leg, and then he moves forward and lands on the next hind leg, and then takes the next canter or in the circle, these horses are going ta-da, 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 just that quick, the hind legs almost at the same time. And that's pretty classic for these horses that have hip fractures or spinous fractures of the hind in that area. He also talked about adult sacroiliac disease, which is chronic. They're reluctant to move back. They're disunited in the hind end. So in other words, they really don't know where their hind legs are, because the damage to the bones can create pressure on some of the nerves or even the veins. And so the legs aren't being innervated properly. So the horse really doesn't know what it's doing back there. And behavior, they tend to refuse to do jumps, and under saddle, they'll hop with both hind limbs. And that was just really weird to watch, to see the horse actually jump up and down with his hind legs. All right, I'm going to move into one more interesting thing that's along the lines of spinal and lameness and things like that. And that was a novel treatment for equine osteoarthritis, intra-articular 2.5% polyacrylamide hydrogel. And this is presented by Dr. Megan Green, who is a product rep for ContraVet that's made in the United Kingdom. pardon me, it's the offices in the United Kingdom. It's made in Denmark. They make a product called Athramid Vet. And maybe you've been exposed to this, but they say it's been 23 years in the making, and it's been with horses since 2009. They've shown high efficacy in humans, and now they're finding that it's working in horses. And the idea is that this is a medical device. It's not actually a treatment of that requires biological materials. In other words, if you have osteoarthritis in a joint and you stick in Adequan, or you stick in hyaluronic acid, or you stick in platelet-rich plasma, all of these are biological interventions. But this polyacrylamide is best thing I can tell you. It looks like a sponge. I mean, if you took a regular house sponge and looked at it, and you saw all the cells, and they're not all uniform, they're all different sizes and shapes. That's what this is. And they're very proud of their manufacturing. They spent time showing us a video and saying that even though it's 2.5% active ingredient, that means it's 97.5% water. They even make their own water right from scratch. I mean, they just distill it and make sure that the water is perfect. And the whole manufacturing process takes 6 weeks to make one of these syringes. Anyway, what it does is it goes into the layer of the joint that is producing inflammatory agents. So that's called the synovium. And the synovium has the intimal layer and the subintimal layer. Don't worry about it. There's no test on this. But that's where the pain is coming from. They release all sorts of factors that make that joint painful. And what this product does is, assuming that it's non-infectious osteoarthritis, it becomes interlaced with the collagen that is next to the synovium. So it limits the macrophage and inflammatory response. So basically, when they inject it, in the first week, it starts to integrate with the tissues that are in the joint. So the tissues see this sponge, basically, and it starts to grow around it. And then somewhere between 2 and 4 weeks, it reinforces the synovial tissue. And they said it's like putting rebar into concrete. It just makes it stronger, and it brings what they said homeostasis to the joint. So in other words, it calms the inflammation down and provides a pain-free joint in about 3 to 4 weeks, which is kind of too bad because you spend money to get this injected and you want horse to be sound right away, or maybe the next day, or maybe 48 hours. But it's 2 to 4 weeks before you actually see the horse getting more sound. The good news is, once it's in there, it doesn't degrade. It stays in there forever. And that's, to me, scary. You know, when you put a foreign object in something, you think that your body's going to mount an immune response and try to push it out in the way of an abscess. But it turns out that the body doesn't react to it. They go up to it, they see it, and the macrophage says, no, we're not interested. And so they don't make an abscess. They don't kick it out. They just say, well, let's work around this foreign object in here, which I found absolutely fascinating. Because, again, you put anything in your body that's not supposed to be there, your body's going to try and get rid of it, or it's going to get sick, or it's going to mount an inflammatory response. And here they're taking something that's absolutely inorganic, inert, non-degradable, and they're sticking it in a joint, and they're saying, no, you'll be okay. I'm like, all right, fine. The company's working with HISA, H-I-S-A, which, if you recall from the last podcast, is the oversight for making sure that horses don't break down. And they are changing the withdrawal time from 180 days down to 14 days for this particular application. And they're saying, yes, horses can start running on this 14 days after being injected, which sounds really good to me. Other groups are working on this too. They did a study where they took horses that were on a scale of 1 to 5 lame, somewhere between a 1 grade and a 3 grade. 0 means no lameness. So a 1 is very subtle, 3 is moderate. And they didn't have any chips in the joints. These horses are 2 to 6 years old, and they injected them with this product, and 83% of them resolved, which is really good at 6 weeks. That's really cool to have lameness resolved with this just one product. I think that's amazing. Compared to hyaluronic acid, which only 40% resolved, and steroids were only 27% resolved. And I said, all right, well, that's kind of cool. So the bottom line is, if your horse has a joint that's not working properly, it's got a dysfunction, it has effusion, meaning there's fluid in there, and has a positive flexion test, then you're okay to use this. So any stage of osteoarthritis, whether it's chronic or acute, doesn't matter. Obviously, starting earlier is better. And improvements has a lag time of 2 to 4 weeks. So they encouraged us to set expectations. And during that 2 to 4 week period, you should decrease workload, and that should help these horses get back on track. They also remind us that this is great for horses with equine metabolic syndrome, because you don't want to be putting steroids in a joint of an EMS horse, because you don't want to be putting steroids anywhere near a horse with equine metabolic syndrome for fear of laminitis. So they're going to do a couple of pilot studies, one of which I don't want to talk about on air. It's, what they do to horses in the research lab is just not worth mentioning. I understand why they have to do it, but forget about it. If your horse has osteoarthritis for whatever reason and meets criteria of joint effusion and positive flexion test, this might be something good to do. I think in the question and answers, somebody asked, how many doses can you do this? And I believe she said 3, and somebody else has said 3. I had another person somewhere say that they would never use this in a joint. So, put your ears to the ground and talk to people and find out what they're all saying. We're trying to get away from putting steroids in the joint because that destroys the joint, even though the horse is pain-free. The other things are complex, they're expensive, and while they're trying to help grow new cartilage and make things happy, here's somebody coming around with a novel idea of, hey, let's put a sponge in it, so every time the horse comes down, lands on that leg, it's not going to be as painful on the synovial tissues. And apparently that's working. But here it comes, folks. It's going to come. What happens if we prevent osteoarthritis? And that's the thing that I'm trying to get across. If we start feeding the horses right, if we start to make sure they have plenty of protein, no inflammatory ingredients, and do proper exercise, long, slow distance, or what I call LSD work, some of these horses should be able to last a little bit longer. I don't know. I really don't know. If your horse slips and falls out in the paddock, that's an injury. You get in a car wreck, you're going to have a bad back forever. I get it. I understand that. But rheumatoid arthritis is common in humans, which is an autoimmune disease, and I believe could be prevented if we knew what caused it, and it's most likely some allergen, most likely a food. And the same thing with horses. I think osteoarthritis has been around for a long time in horses, but I think it's just getting more common. I mean, back in 1980s, 84, it's rare that we injected a joint. All of a sudden now horses are getting every joint injected with everything under the sun, trying to make them sound enough to keep performing in their show ring. And I just don't understand it. Why are all these horses getting lame, getting osteoarthritis? So that's my thought for you guys to think about. I'm going to end this and come back with another podcast with a final episode, which is all going to be about metabolic syndrome in horses, which I think was fascinating, plus a couple of other things. All right, so I guess vitamin E is one, and what was the other one? I've already forgotten. Anyway, that's why I'm doing these so quickly after hearing them, so they're not just distant memories. Thank you for hanging out with us. I look forward to you coming back next week and mucking through the last episode. And I promise you that'll be it. And I'll move on to something better. Although this is kind of cool too. All right. Thanks, guys. Talk to you later. Bye.
Hey, everyone. Doc T here. Thank you for listening to my content. Would you do me a huge favor? Would you please subscribe, comment, like, thumbs up, and give a star review? However it's presented to you, I want you to do that. There's two reasons. The first, of course, is to improve this product. This way I know what you like, what you don't like, what I can improve upon, what topics you want me to cover. But more importantly, it's also going to help others find me. And by doing that, you are now engaged in this mission of helping horses thrive in a human world. By you helping, we can reach others. And that I would be so grateful for. And remember, go to thehorsesadvocate.com for updates on this information. Thehorsesadvocate.com. And again, thank you so much for being here. Doc T out.